And a warm welcome back to WoundCasters by Wound Care Today. I'm your host, Felix Boecker, and today I'm excited to share another amazing guest with you guys. Kathleen Schaum, the president of Kathleen Schaum Inc., is also an editorial advisory board member for Wound Care Today, and I'm excited to have her on the show. Let's hear all about how you got to be involved with Wound Care Today.
Well, Felix, first of all, thank you for inviting me. And I have been in the reimbursement space now for 57 years. So that's a long time.
Yes.
And I actually have been educating providers and manufacturers and speaking and writing for a long time. And I selected to be in the wound and ulcer management space for reimbursement because I felt that there was not a lot of education for the professionals in this space about reimbursement. They're miracle workers for their clinical work, but not a lot of education in reimbursement. So that being said, is what I've done for a long time. And I'm so excited to work with Jeremy Bowden and his staff because they've been just such professionals in this space. And I've worked with them in other opportunities and other work that we've done together. So when Jeremy said that he was going to start this particular initiative, I was excited because I think it's cutting edge and it's going to give us the opportunity to bring short but sweet messages to the clients when they need it. And of course, at times we may be doing some longer presentations to them, but it can be much more real time.
Yeah, that's incredible. I honestly, I've always known you as the reimbursement person in wound care. I've seen you at conferences and I've seen you on other podcasts, your own podcast. But I had no idea that you had over 50 years of experience in this space, which to me begs the question, how has the reimbursement field changed over that time? And I say this because I have not been at it for over 50 years. But I have seen my own changes in the reimbursement space over the last 10, 15, 20 years. And you're absolutely right that as a physician, I was trained on the science, the physiology, the anatomy, but the reimbursement was not something that was ever taught in medical school. Coding and billing is something that wasn't even really addressed in my residency. Even though as in a surgical training, we had to keep a case log. So we had to save our own CPT codes for the procedures that we were trained on. But how that then translates into reimbursement and billing is something that was never really addressed, even in the more senior years of my training, which really is I think a problem with our medical education, because this is our livelihood. This is, if we don't get paid, we don't eat food. So I know a lot of things just from the periphery that have changed, but I'm curious about your perspective being in the trenches of the reimbursement space. How has the game changed?
So I will tell you, when I first began in the whole reimbursement world, there really wasn't the payment systems that we have today. And there weren't the various places of service that got separately paid like today. Basically, there were hospitals and physician offices and some nursing facilities. That was about it. And for wound care, if you needed something like a dressing at home, there was no separate payment for that. All of that had to come out of your pocket. So I watched things like surgical dressings become a Medicare benefit. and then have a local coverage determination to tell us how to code for it, how to document for it, how to bill for it. Then I watched the DRGs go into place. Way back before DRGs, each state had a different way that they paid their hospitals. And I happened to be in one of the demonstration hospitals for the DRGs. There were 10 hospitals originally. And that all started in the state of New Jersey. And before the demonstration was over, it became a law in the United States, and everybody got paid by DRGs. But the moment the DRGs went into place, keep in mind, before that, patients stayed in hospitals for a long time.
Right.
If they needed any special care or whatever, I mean, if you had a heart attack, you might be there 6 or 8 weeks. All right. And so once the DRGs went into place, the hospitals had the reason to get the patients out of the hospital quickly. And so then we started to see the different places of service pop up. We started to see home health take more difficult patients. We saw skilled nursing facilities come into play. We saw the hospitals develop outpatient departments where patients would get discharged from the hospital and then come back to receive ongoing care. So many sites of care popped up that we didn't even have payment systems for. So in the year 2000, which is now 25 years ago, all these places of service got pretty much a new payment system, except for the physicians. All right. And they were more prospective payment systems similar to the DRG, but the hospital was paid based on diagnoses, and all the other places of service typically paid more on the work that they did. So, I watched that all happen. And then once we had surgical dressings taken care of, then popped up new technologies because we needed to take care of these patients at home. So that's when we saw things like negative pressure come on to being. We saw the physicians doing more procedures in their office, and the growth of debridement. We then came along hyperbaric oxygen, and then the various products that we have today, as well as the diagnostics, etc. So none of that was a master plan. And because it wasn't a master plan, the payment systems, particularly for the Medicare program, had to adjust and get created along the way. And so they're disparate systems. Each one was created in its own silo, and we still have to follow all those silos today. And that's why it's rather difficult for anybody coming into the medical field to understand that not everybody gets paid just like you get paid. And so I have seen this change. And so in my 57, 58 years here almost, I don't think there's been any 6 months the same as the last one.
Wow.
And what I've been also seeing is the manufacturers, they, particularly the R&D people and the executives at the top, haven't necessarily studied the fact that all these places of service where they would like to push their product out to have different payment systems, and they have to decide, can we fit all of them, or can we only market to a certain place of service? So it's a moving target. And when you say you haven't learned in medical school, I know that because just trying to teach this to the physicians, the podiatrists, the nurse practitioners and PAs, it's like teaching them a foreign language. And unfortunately, when I get them, usually they've already learned from each other. And
Yes.
sometimes learning from each other doesn't give us the best product.
Right.
So it really is a very confusing situation right now.
Yeah. And speaking of confusing, I mean, one of the trends that I've been seeing, at least with my population, is because it is so confusing and convoluted and ever changing, a lot of patients are even frustrated by the system, and they're deciding to go the route of self-pay, just to not have to deal with all of that. So where do you
Mhm.
see that fit in, and how is that self-pay side of things changed over the last 50 years? Because like you said, in the beginning, we didn't have all these payers. It was a lot more direct payments from the patients to the physicians, the products, the hospitals, and whatnot. And then we introduced these third-party payer systems into the mix, and now we're making all the policies and regulations so convoluted that's almost impossible to stay current and stay up to date, unless you're listening to your podcast. Yeah, where do you see self-pay fit into the mix with all of that these days?
Well, um, people who are not really sick, okay, uh, probably can afford that very well. And people who are on the higher income level can probably fit that very well. Because if something really big happens to them, they would be able to have the finances to take care of it. And I mean, I know the concierge services and all of that are out there are really very good, but they can only handle a certain number of patients. And then if the patient doesn't have insurance and he or she had to go to the hospital for some major big deal, then indeed that could be very problematic and it could wipe them out
Yeah.
financially. So when you say self-pay, I think you have to weigh that. If we're only talking about self-pay to a physician or a physician type, but they keep their insurance,
Right.
that's probably the better way to do it right now for the majority of patients. But to just say we're going to just give up our Medicare. We're going to give up our Medicaid. We're not going to have any other insurance. The catastrophic things that happen to us, which we can't prevent, are scary.
Yes.
So I think when we say self-pay, we have to define that. What do we really mean by that?
I think that's a good point, and I think at least the people that I've interacted with, they look at it just like what you described. The catastrophic events, the big ticket items, the unexpected heart attack, the unexpected stroke, right? Those things that end up in the hospital, that get really expensive. That's what the insurance is used for. But the weekly wound care visits, sometimes even dressings, trying to get dressings through certain distributors has been really difficult because they don't have contracts with the various manufacturers, or they just don't know how to source a particular product. And so your physician wants to use a certain type of dressing, and the distributor, the home health agency, can't provide it. While the patients go out and buy it out of their own pocket, to circumvent the system and get the care that they feel is necessary, without having to deal with the rules and regulations that are, in their minds at least, slowing them down. So I think that's a good point. That I don't think it's a complete dismissal of insurance. I think it's really just leaving it for the big ticket items, but for the day to day, the smaller items, and especially in the wound care world, I see it a lot with dressings that patients go out and buy on their own because they're not able to get the dressings that their physician prescribed, aka me sometimes, through their home health agency. or local distributor. So that's definitely a good point. So you have the podcast for Wound Care Today on reimbursement, where you educate others on all these ever changing field of reimbursement. But behind all that, you still have to educate yourself. So how do you stay current? Because to me, it's almost impossible to try to stay on top of the science and the reimbursement, right? And all the different rules and regulations on my licensure. It's a bear. It's a bear. So what do you do to try to stay current with this ever-changing field?
Well, Felix, that's a really good question because people don't realize when I get in front of them and I deliver them a succinct message. Here's what you're doing and here's how you do it. There's not a book that is written about that you can just pull that from. It takes reading literally about 1,000 pages a week to just keep on top of what's going on and then to assimilate that back to what the professionals need or the manufacturers need, or I even do work for investors. All right. And so everybody wants to know from their perspective, how do I deal with coding, coverage, payment, documentation? And you don't really find it written in a book or in a rule that here's exactly how you do it for wound and ulcer management. You have to pull that out and stay on top of it. I will tell you, it's the hardest part of my job. People don't see the effort that goes behind the scenes to stay on top of the knowledge. I mean, to do a 1-hour webinar on any hot reimbursement topic might take 20 hours minimal to prepare that 1 hour of education. And, when people hear it, they think, oh, that was simple, Kathleen, But it really wasn't. And it really isn't. Especially if you're going to keep them up to date with every little nuance that's happening now.
Yeah. Let me put it this way. I always knew that there was a lot going on. I didn't know how much. For you to say that you have to spend, reading 1,000 pages a week. I mean, that's monstrous. That's a lot, just to stay current. And I guess
one other thing I'd say to you, I haven't read a good book for a long time, Felix.
What are you?
Because I don't have time to read something for fun, if that makes any sense.
Wait, are you saying LCDs are not fun to read? So,
or proposed rules.
Yes, right. So do you mainly focus on Medicare though, or like the federal payers, or because private insurers they bring a whole nother ballgame into the mix on the commercial side of things?
Well, that's a really good question. First of all, Medicare sort of sets the tone. All right. It doesn't mean that the private payers all align,
Right.
but Medicare sets the tone. And in wound and ulcer management, until recently, the lion's share of our patients has been in the Medicare program. So I try really, really hard to stay on top of all of the nuances and the rules and regulations about Medicare, straight Medicare. And then when we talk about Medicaid, remember Medicaid, every state has different programs. The state of California has a different Medicaid program in every county. All right. So then what providers have to do is take what you learn from Medicare and then look at your exact contract with Medicaid, with your Medicare Advantage programs, et cetera. And there, I think, is one of the areas that the professionals actually fail in, because they want to get on these panels. They want to have a contract with the payers, the private, the commercial, the Medicaid, Medicare Advantage. They want to be on their list of providers. And so they sign these contracts, but they don't read them. And those contracts they're like the LCD, okay, from Medicare, because there's a lot in it that professionals don't pay attention to. And then on top of that, each of those payers have their own medical policies.
Right.
And then, so you have to stay on top of that. But then each of those payers also has maybe 100 different plans. And so you have to understand what's going on with that patient's plan. So to me, I try really hard to teach people how to read their contracts, negotiate their contracts correctly, all right? How to stay on top of the medical policies that pertain to them and the work and their patients, and then how to set up an insurance benefit verification system correctly, so that they can determine if something, not just if does the patient have that insurance. That's the first problem. Okay. But then is whatever you're going to do for that patient covered on that patient's plan? And honestly, when I see people do insurance benefit verification, it sometimes makes me cry, because they call up and they want to know, is Mrs. Jones have this insurance? And they say yes. And then they will say, well, do I need prior authorization for this? Very often, the insurance company will say no. And so the professional will go on and do it because they got a no answer. But they asked the wrong question. They asked, is prior authorization required? What they should have asked is this procedure covered on this patient's plan?
Yeah.
Fail to get that. They asked if they have the insurance. Then they say, here's what I'm interested in for this patient. Do I need prior authorization? And if it's not covered, very often the insurance will say no, because guess what? It wasn't covered. But they didn't ask if it wasn't covered. So those little nuances, you ask me, what do I end up teaching? I teach people how to interact and how to be sure that they are interacting with these other payers just like they would interact with Medicare. Yeah. And it's interesting because what you teach them to find out if something's covered with a commercial payer, for Medicare, you can't ask them, except for a few things. You can't ask them, is it covered? You have to look at the LCD and you have to decide, are you meeting every requirement in the LCD? Medicare is not going to tell you that until they do a payment audit or a post-payment audit, and then they'll tell you if you didn't follow the rules. And then the hardest question is, well, if there's not an LCD for Medicare, then what? And it's very clearly written. It's a law that it has to be reasonable and necessary. And that has to be proven in the documentation. And I can tell you that's where we fail a lot. We do such great work in wound and ulcer management, but we fail to paint the picture of what we do. And we fail to blow our horn. It's sometimes when we look at the documentation, it kind of looks like a Van Gogh painting. All right? All over the place. But it doesn't picture of exactly what we did. All right. Succinctly, what's the picture today? I would like to see those pictures be more like Thomas Kincaid, the painter of light, who everything is exactly perfect. All right. And you don't have to write 15 pages to get this. You could get this done in a short space if indeed you think it through. So we have, there's a lot of different things, as you can see. Some things we have to do for Medicare different than the commercial payers, and teaching that to the professional who's also trying to run their business and see patients every day gets a little difficult. And so very often what I'll find is the professionals will talk to each other. Now they'll say, well, you don't have to do that. Look, we're getting paid. We're getting paid. You don't have to be that precise. But Felix, I used to worry about wound and ulcer management professionals getting paid. I don't worry about them getting paid. I worry about them keeping their money, because they do this great work, but very, very often don't tell their story in a succinct, clear way.
Yeah. That's very true. I mean, I just want to circle back to one important point you made, and that's asking for pre-authorization versus asking for coverage or asking about coverage. I think that is a very important point that I think just bears mentioning again, because it's a very subtle difference in the wording, but it is so profound what the impact of that is at the end of the day, right? So that's important. So when it comes to all this education that you do, even with your own podcast now, what are like the hot topics that you hear about all the time coming from providers, from physicians, from anybody who's other manufacturers even billing? What are the hot topics that everybody asks about? And the reason I'm asking that question is because that's an educational gap. If everybody keeps asking the same question, that means everybody wants to know this, but no one has taught that.
Well, it's interesting. When we began my little podcast called Reimbursement Readiness, I selected three friends, three other colleagues who are very, very good reimbursement specialists, and we all have a different point of view. Not disparate, but we all specialize in an area. And why did I do that? Is because the questions come from all points of view. All right, but we decided that we had to start at the beginning, which is what people ask. My phone rings all the time, and I pick it up, and people say, "Can you tell me the code?" What code should I know? And it doesn't matter if they're asking me a procedure code, a product code, a diagnosis code. They focus on the code. Of course, because from a provider standpoint, that's important, okay, because that's what goes on your claim. But they don't understand that after the code, we then have to figure out documentation, coverage, and payment. And those things are all just separate. So we decided that we actually started with coverage. So reimbursement readiness, its first couple episodes are on coverage. We'll continue. If we ran this podcast for years, we'll still be talking about coverage because it always changes. But we laid the groundwork for that. And then we laid the groundwork for coding. All right. And then we'll be talking about payment next. And then we're going to talk about places of service. So there's so many pieces and parts to this, but I have to tell you, it's about coverage. All right. Because they ask about codes, but when it comes down to it, it's all about, will this be covered? because if it's not covered, it doesn't matter what the code is. It doesn't matter what the payment rate is. It matters, is it covered?
Yeah. And it goes back to your previous point, right, of pre-authorization versus coverage. The question is this covered? So that's very good, driving that point home. One thing I can tell you from my time in the field is coding is something that I have always struggled with, and part of that is I've never gotten the training for it. There's people who go to school full time, for 2-year, 4-year programs to learn this stuff, and I didn't go to school for that, so it's something that just is as an aside came about. But the other piece I struggle with is a lot of times people don't fit neatly into a specific coding category. And then I struggle. Well, what do I do here? What do I do in these situations where a patient doesn't fit neatly into a coding category, and I need this code in order to get reimbursed potentially? And I think, if anything, that's probably where a lot of these coding questions come from. Is if you can't fit someone neatly into a predefined box, where do they go? I do want to ask that question, though, right here on the show, because you do get a lot of coding questions. What do you do about coding when a patient doesn't fit neatly into a category?
Well, again, the word coding that you've just used, if you ask me that question on the phone, I'd say, Felix, are you talking about a diagnosis code? Are you talking about a service, a procedure, a product? What first? Get me in the
Okay.
right church. Okay.
Okay.
We have to know which coding system are we talking about? Where doesn't the patient fit? Sounded to me, I'm not going to pressure you on that because you didn't have an example, but sound to me like when you say they don't fit, it seems to me you might be talking about diagnosis.
Yeah.
All right. And so if what we have to do is we have to get as close as possible and also know that in the worst case, there is a non-specific code. All right. Very often though, that's the kiss of death. And so I always tell people, let's look at this very, very carefully. With ICD-10, we have a much better ability now to describe our patients. I mean, just this 2 weeks ago, we got even new, more specific diabetic codes. So that's number one. The other thing is know that if you have some specific diagnosis codes or diagnoses, issues going on with a patient, and you can't find a diagnosis code for it, you can work with your specialty society, and there are consultants. In fact, one of my friends on reimbursement readiness does a lot of this work to get new ICD-10 codes. So there's no limit to the number of ICD-10 codes that can be in that book. All right. That's the beauty of ICD-10, is it's very expandable. Unlike ICD-9, we ran out of codes because of the way it was designed. And as we move into ICD-11, there will be even more opportunity. So when something doesn't fit, there is a non-specific code, but I say if it's something that's routinely you can't find something, then it's probably time to get a new ICD-10 code. And it's not that hard. Takes a little work. Takes somebody who knows how to do the application. Takes your specialty society to be behind it, but it's very possible.
That's good to know. That's awesome. Like with everything in medicine, it's not necessarily difficult, but it does take some time and effort to get the work done. So I do want to know about your podcast. How has that been going for you? How long have you been doing it? And how's it going for you on your
Let's
show?
see. I actually sort of forget when we began this year. Okay. But we are doing them every other Thursday. People might not realize that they come out every other Thursday. I think we're on like episode number 10 right now, so it's relatively new. But I'm working with my friends, and we have already produced more than the 10. And it's been really a very good thing, because I'm getting a lot of emails, and so are my friends, back saying, oh, that you really, you're nailing what we needed to know. You're teaching us the basics, because if you don't understand the basics and you don't understand the foundation, then how can you understand something that's more difficult? So we've been getting a lot of good response that way. And we let it open where anybody could send in questions to my email. And then we're trying to build the answers to those questions into future podcasts. I've said to my friends and to Jeremy that, we could probably run reimbursement readiness till I die, because there's so many topics to talk about.
Yeah.
We're trying to do it in these snippets. When we think someday we'd probably like to do some longer programs, because certain topics you just can't get in a short podcast. So we've had to weigh what can we get in a podcast, and then what would we do with topics to take a little longer to explain.
Yeah.
But we're excited about it. I can tell you, my friends and I, this is something that we've been spending a lot of time for. And even though it's short, I have to tell you, sometimes the time to spend to get ready to do a short podcast, particularly in reimbursement, so because it's so detail oriented, probably takes longer sometimes to do than it takes us to do a big program.
No, I could definitely see that, because you're really trying to condense it down into really just the fewest details possible, while still maintaining enough details to be relevant. So I can definitely see that, right? That
Yeah.
the shorter podcasts take longer to prepare.
Right. Well, plus we found a little ticket, a little way to help, and that is that we have been, for many of the podcasts, we have been creating a handout, that
Oh, that's
the
nice.
listener can grab on to that handout. It's kind of like the cheat sheet. All
Hmm.
right. Of, here's what we talked about, but here's some details for you for implementation. And I've received a lot of thanks and compliments about those handouts, because people say, oh, wow, this really helps. This helps us, and as you know, if this is the first real education they're getting in reimbursement, they appreciate the cliff notes.
Yeah, no doubt. It's a wonderful podcast. It's available at Wound Care Today. Are you on other platforms as well, like Spotify or Apple Podcasts, or are you just on Wound Care Today at the moment?
No, I believe that Jeremy has now released it to a variety of the media, um, and I'm pretty sure it's Spotify. I'm sorry, I don't remember all of them. Do you remember? Do you know any of them, Felix?
So I know that this podcast is now on, not just on Wound Care Today, but on Spotify and Apple Podcasts as well. And I think the Google platform is coming along as well at some point. But at least as of this recording, we're on Spotify and Apple, along with Wound Care Today. So I would like to think that you are as well.
I think, and this is so recent that I have been busy producing these things, but I really believe that they're on the same platforms as you're talking about.
Yeah. So, and I would urge anybody listening to this episode to go check out reimbursement readiness and make sure you leave a good 5-star review and maybe a comment or two if you can, because it helps other people find the content more easily and more readily by bringing it up in the podcast feed. So that is fantastic. So throughout your experience, what would you like to take listeners away from this podcast episode today that might limit the amount of phone calls you receive?
If they're a new professional just getting into the business, and we have a lot of new people coming into wound and ulcer management. Okay. In fact, at the last major wound symposium, greater than 60% of the people were new. That's
Wow.
a lot.
That is a lot.
Okay. So if you're new, I suggest that you meet with a reimbursement consultant at the beginning, before you have even seen the first patient, so that you understand, here's the procedures, services, products you're going to use. Here's where you're going to do it. Here's the rules that are surrounding that. Then you will know how to set up your EHR. Then you will know how to set up your billing system and things, and you'll know how your documentation has to be like, a very good, clear painting picture of your work. And I would like to see them do that early, before they proceed. Then everything is set up, because if they don't do that, now, like you, all right, and I don't mean you haven't done this, but you, as you said, you didn't learn it. All right.
Right.
You've had to learn it along the way. Well, once your system kind of gets set up, you get set up in this way, but now we tell you, no, you need to do it this way. And it's harder to change. It's easier to set your system up right than it is to change it later. So I would say to the new listeners, do that. Of course, to the more seasoned wound professionals, I would say to them, if you haven't really learned all the rules about coding, coverage, and payment for what you do, you really should take the time, whether you go to a symposium, whether you listen to reimbursement readiness, you read some articles that we've written, whatever you do, take the time to look at this and audit yourself. If this is the rule, print your darn documentation and read it. Don't look at the screen on your computer. Print it out and read what you do. All right. Read what you wrote that you do, and be sure that it meets all of the criteria that you would need to meet in an audit. And if you don't, fix it. All right. Don't go, well, it's good enough. No, it's not good enough if it doesn't meet all the criteria. All right. So to me, for the seasoned person, is know the rules, then print your documentation and audit it. Very often the professionals don't print their documentation. They don't look at it until they have an audit. And now they send this Van Gogh painting into the auditor, and they wonder why they didn't get a passing grade. And it's because it wasn't clear. And then I would like to make one suggestion to the manufacturers, all right, who may be listening, is I would suggest to the manufacturers, when you are thinking about developing a product, when you've had a drawing on the napkin of what you're thinking about, contact a reimbursement consultant. You won't need them for a long time. Just at first, if I had this product today, would it get paid? Would it be covered? Would there be a code? Or what steps am I going to have to go through in order to make that get a reimbursement status that I like. All right. Because they might be able to, if they see that it's a rocky road, they might be able to make a few tweaks to that technology to design it in just a pinch of a different way. And then it might easily flow through the system. I find that manufacturers don't do that. The very first thing they focus on is getting through the FDA as quick as I can. And then once we've gotten through the FDA, we've drawn the line in the sand, we've put our stake down, and we've used words and semantics that I can't change when I go to get them reimbursed. So to me, it's a parallel path. Think about reimbursement early and FDA, coordinate them so that once you get your clearance, we will be able to be positioned better to get reimbursement, coding, coverage, and payment for them.
Yeah, that's a really good point, and I think at least from my experience with coaching entrepreneurs and working with startups, it's always a shoot first and ask questions later approach. Let me just get this product out there. Let me start, and then I'll figure out how to make money later on. But I got to get this product out into the market, right? And especially in the world of healthcare, the reimbursement, the payment is not as easy as it might be as selling something at Walmart or Target. So you can't just put it on the shelf and expect people to buy it from you and get paid. So that's a really good point that you make to work with the reimbursement side of things in concert with the regulatory approvals. That's fantastic. So with all your experience, everything you have seen over the last 50 plus years and everything you're still doing now, what do you think, how do you think the landscape is changing? What's coming? What should we be aware of, afraid of? What do you think is sort of the next big change that's happening in the reimbursement space?
Well, we're in a things are happening today that we thought were like Star Trek long ago. Okay. And so it's hard to totally foresee, but I think we're going to see a lot more in diagnostics, but probably at a much more higher elevated level. I think the use of technology, the use of AI in some good way is going to help us. I think sensors will be important. Remote monitoring is going to be important. And I think that for me, figuring out how, as this comes along, how to get it paid in a system that wasn't designed when this technology was available. All right. And I think that that's the thing that's going to be the hardest is whatever we design to help us in wound and ulcer management, if it's unique, if it's very computerized, AI worthy, etc., then indeed we have to get a code for it. Right. Oh, and then we have to get somebody to cover it. And then, will the payment rate that gets assigned to it be able to pay enough for the technology? So, Felix, I don't even know. I can't even imagine what it's going to be like 10 years from now. I do know this, that we have had a difficult time, even with some of the imaging things that we've brought to market. All right. Yeah. We've had a difficult time fitting them into the system that exists. And so I think that should be a real clue to everybody that you have to think about this early, and we have to think about talking to the payers early, talking to everyone and being sure that we know how this fits and what changes do we have to make to our coding system. I mean, AMA, for example, created some codes this year that CMS said, well, you can have, great, you made the code, but we're not paying for it. So I think that's why I say we have to, whatever it is we do, we have to think about it early. We have to talk about it and say, okay, if we had it right this moment, would it be paid? Would there be a code? Would there be coverage? And if not, what do we have to do to get there? And I think the sky's the limit. I mean, it's probably beyond my comprehension of the things that we will be doing for wound and ulcer management. But I do know whatever it is, we have to figure out how it's going to fit into the reimbursement system.
Yeah. Well, this has been an absolutely incredible conversation. Thank you for taking the time for being here. How can people reach out to you if they want to know more about you or they maybe want to work with you? What's the best way to get in touch?
Well, I absolutely have no problem for people to call me. All right. And I have one phone number, and it is a mobile phone. So it's 561-670-7176. I answer my phone myself. I hardly ever have something go to my answering machine. And I'm very willing to speak with people. And I'm also you can text me also. I'm also very willing to receive questions or requests via my email, which is my name, but it's my middle initial included. So it's Kathleen D. Schaum at gmail.com. KATHLEEN, then a D, then SCHAUM at gmail.com. I will tell you, if you ask me a reimbursement question, which I have no problem to do and see it in an email, I will always respond by saying, please call me or let me call you if you give me a number, so we can talk about the answer, because usually there's more to the question than is put into an email. And so I always want to know, what's the question behind the question? And that's the best way that we can help each other.
Wonderful. Yeah, you're absolutely right. It's about helping each other out in this space. Thank you again for taking the time for being here today. And thank you for all your wonderful insights. Thank you for what you're doing for Wound Care Today with your own reimbursement readiness podcast. And with all that, thank you all for joining us today on WoundCasters by Wound Care Today. If there are any particular topics you want to hear about or guests you would like to see on the show, reach out and contact us. And if you're listening to this on a podcast app, be sure to subscribe and leave us a 5-star review so others can find this content more easily. If you like this particular episode, please share it with a friend. And as always, be sure to tune in next time as we explore yet another aspect of the challenging and rewarding field of chronic wound care. Ciao.